abduct and extort when binocularity is suspended by occlusion or spontaneously when fatigued. May be manifest or latent only when the eye is, that is when the eye is covered. ये क्यों नहीं आ रहा है? Okay, आप इधर खड़े हो फिर. So the characteristics are it's always bilateral, associated with anomalous head posture, commonly a head tilt. And it also occurs, like suppose after we do a infantile strabismus surgery, we find that we do get dissociated vertical deviations or a DHD after following surgery for the esotropia. So we have how we measure is by the prism cover test. So a translucent occluder may be placed to disrupt fusion, and then you measure it under the cover. So you put base down prisms are placed in front of the dissociated eye, and then you stop. So means you measure it, and then you say this is a deviation when there is no downward movement of the eye. So you can have small 0 to 9 PD, or moderate 10 to 19, and greater than 20 PD. So what are the indications for surgical management when there's increasing frequency of manifest DVD, or patients with anomalous head posture, or DVD that is large and occurring infrequently? So let us take case by case. So this is a large unilateral large DVD with amblyopia. So she has in the left eye measurement of around 15 prism basin and 15 prism, and there is a DVD of around 15 prisms. So it's a exotropia with a comitant unilateral DVD. So now should we touch both eyes, superior rectus, or should we do only one eye? So unilateral superior rectus recession was done. So several authors have advocated that bilateral should be done for all patients with DVD unless we have a dense amblyopia which is present in the non-fixing eye. What we find is that once you operate one eye, then the other eye again there's a fixation preference, and the DVD again occurs in the other eye. So this is the post-operative picture, and she's doing well. Then you have symmetrical or asymmetrical DVD, where you can like in this measurement, what you see that in the right eye it is DVD is around 14, and the left eye it is around 6. So it is comitant, but it is asymmetric. So in these cases, you could do an asymmetric superior rectus recession. So this is like a 45 basin with asymmetric DVD. So asymmetric superior rectus recession was done. So both eye lateral rectus recession with 9 and more in the right eye than in the left eye. So this is the post-operative result. So now we did a study of our own patients. So bilateral symmetrical and asymmetric superior rectus recession for patients with DVD. It was published in Asia Pacific Journal of Ophthalmology. So what we found was that the mean follow-up was around 12 months. The mean preoperative DVD measured 10.1 plus or minus 5.1 prism diopters on the right eye, and 10 plus 6 plus 7.6 on the left eye. So we found that DVD became latent in both eyes in 64.3% patients on the last follow-up, but failed outcome was seen in DVD if it was measuring more than 15 prism diopters. So we had to do the second step of inferior rectus resection or IOAT if the DVD was more in the primary, more than 15 prism diopters. So now you have incomitant DVDs. So now we should know about incomitant DVDs are DVDs with inferior oblique overactions. So here you find that there is more, it is more in adduction than an abduction. So in these cases, they are associated with inferior oblique overaction, and there is associated V pattern. And so here you can see that it's more in adduction than an abduction. In these cases, what you plan is an IOAT, that inferior oblique anterior transposition. So you could also do an asymmetric inferior oblique transposition for if there is incomitant or if there is asymmetric DVD. Then we can also have DVD, which again is incomitant because of superior oblique overaction. And this DVD is greatest in abduction with superior oblique overaction. So you have a triad of DVD with superior oblique overaction with A pattern. And in these cases, you would do horizontal surgery, superior rectus recession, and PTSO. So, so it's a triad, and we have to treat. So PTSO is done. So this you can see that, see again in this video, you can see that it is more in abduction than in adduction. So in our case series, we published a case series of the triad, and we took an inclusion criteria was bilateral incomitant DVD with superior oblique overaction, A pattern, and greater than 10 prism diopters. So this, what we did was a simultaneous surgical correction, because we didn't want to, because the patient may not come back. So it was we had a case series where we did all the 6 muscles together. And we found that we did as a single stage procedure. We found that A pattern decreased from 26.25 to 8, and there was average collapse in the pattern was 18.25. DVD in the primary position also decreased. Though we did not get any ESO with the PTSO done in both eyes. So that was something which we had anticipated, but we did not get ESO we did not get an ESO of 8 prism diopters when we added it to the horizontal deviation. So next is, this is a child with a large DVD. So we thought like, so this is a large DVD of 25 to 30 prisms. So we said that, okay, now, so the surgical procedure we normally do is superior rectus recession with inferior rectus resection, because it's a large DVD. So we thought of doing a posterior fixation could be one option, like a Farden, or we thought we'll do the Y split. So the Y split procedure, so we had an exotropia of 25 to 30 PD, DVD, and an A pattern. And we can see that the A pattern is around, it's not large, it's around 15 only, 15 to 16. And so we planned a bilateral lateral rectus recession with a superior rectus Y split. So now this procedure, this procedure is been, I found only 2 papers published, one in preprint and one published paper. So I was wondering what the results could be. We found the same results, but I still feel Farden because I still had a residual after surgery. So the Y split is an option, but I mean, like, we have just done 2-3 cases. So I'm seeing that there is still residual when we are doing it for large angles. So it is not giving the same effect as what you thought that it could be with a posterior fixation suture or a Farden. But this could be considered. So you have the superior rectus, which is split into 2 halves, just like a Y split which we do for Duans in a lateral rectus. And then you take it, you split it has at the length of 40 millimeter from the insertion, and then you detach it from the globe, and then you attach it to the, so how much recession to do? The recession which I did was around 7 millimeter. So maybe for a 25 to 30, maybe you could do more recession, because I still had a residual of around 10-15 DVD. So this is how it is done, and you place it, so a 7 millimeter recession was done. And then you place it 20 millimeter apart. So this is how, it's just like the Y split for Y split which you do for lateral rectus in your Duan's cases. And you have to only be careful of the superior oblique here. Be careful of the attachment of the superior. You can cut off the attachment of superior oblique to the superior rectus, but be careful that you isolate it, and be careful that you do not cut the superior rectus. So this is the superior oblique which we have just seen. And so this is the result. Though after some time we found that there was, in the right eye, there was still residual DVD, so which we may have to do our inferior rectus plication later on. So I looked up literature, so there was only one paper published, and this was like they have done in 3 arms. One, they did the superior rectus recession in one arm, and the second arm they did a 3 millimeter recession with a posterior fixation, and the third arm they did a splitting of the superior rectus muscle, and they found that Y splitting was to be a safe and elective surgery method for surgical treatment of unilateral DVD with bigger deviation angles. So this could be a good alternative to posterior fixation surgery. So this is another boy with 14 years old. So mainly you find that global developmental delay children have problems. They have DVD, and they have problems with virtual perceptual skills and dyspraxia. So we did an exercises, but we found that the boy could not do any geometrical, like he could not make any geometrical on the protractor, any circles or anything. So he was saying that please make eye drifts up, so please make it okay. So we did a superior rectus recession surgery. Along with that, there was still residual DVD, so we planned a IR plication. So IR plication is as effective as superior rectus recession with posterior fixation sutures, and it can be used effectively for the treatment of residual and recurrent DVD. And then what he tells us that after the surgery that he can, his geometry has improved. So it is not, so we have to perform these surgeries for improving all the other cognitive development of the child also. So it DVD represents a common and most challenging form of strabismus for pediatric ophthalmology and strabismus surgeon. Thank you. Any questions?
Thank you, Dr. Suma, for that wonderful talk and so many surgical procedures you have told. I just want to say one point that I think DVD as a devil never dies. So it's basically the lack of binocular vision that makes one eye drift upwards. So whatever we do, we can just make it latent, but we
Yes.
cannot correct it. That should be emphasized on the patients from the beginning, that they shouldn't expect a correction,
yeah.
just a suppression of
Suppression,
DVD. I welcome Dr. Ramesh Kekunia to this course. I would like to, anyone from the panel would like to ask a question on DVD to Suma?
When it is latent, then it's best to give the refractive correction. So refractive correction helps us in controlling the latent DVD. So for a manifest DVD, I think it's best to operate. Hmm? I don't do pulley fixation. You tell us.
Yes.
Actually, Dr. Andrea is there. Ask. Dr. Andrea.
Yeah. And Dr. Andrea, would you like to comment on? Uh, can you give her the mic? Give her the mic. Yeah.
I totally agree with what Dr. Suma said. Definitely, also my first choice are superior rectus recessions. But I agree, I'm using more and more inferior rectus plication for these cases, for severe DVD.
Yeah.
Thanks